Hello, dear friends. Today we are talking about portal hypertension syndrome and liver failure syndrome. Portal hypertension is determined when the pressure in the portal vein rises above 7 mmHg. However, it's clinically manifested when the pressure rises above 12 mmHg. Portal vein collects blood from the lower part of esophagus till rectum. Portal veins inflow are left gastric vein, splenic vein, inferior and superior mesenterical veins. In case of increasing pressure in portal vein, we have increasing pressure in these arterial veins and also they're enlarging. Also may increase pressure and enlarging umbilical veins in case of non-obliteration. There are three types of causes of portal hypertension depending on levels. It may be pre-sinusoidal level or in sinusoidal level or in post-sinusoidal level. Pre-sinusoidal or extrahepatic portal hypertension may be caused by thrombosis of the portal and splenic veins, hepatic sarcoidosis, and also schistosomiasis. In sinusoidal or hepatic cases, it may develop because of cirrhosis of liver or congenital hepatic fibrosis. Post-sinusoidal or veno-occlusive diseases, they can develop because of Budd-Chiari syndrome, for example. In Budd-Chiari syndrome, in the level of the inflow of inferior hepatic vein into the vena cava may be stenosis or formation of web or thrombus formation. To better understanding of clinical picture of portal hypertension, you should remember portal caval anastomosis. There are three types. First, anastomosis in the area of cardiac part of stomach and esophagus. Blood from the portal vein enters the inferior vena cava through the venous plexus of these organs through the azygos vein. Second is anastomosis between the upper, middle, and lower rectal veins. In these cases, blood from the upper rectal veins through the system of anastomosis enters to internal iliac veins and further into the inferior vena cava, and anastomosis between the umbilical veins if it's not closed, dumping blood from the portal vein through the umbilical and further into the veins of the anterior abdominal wall where the blood flows into the inferior and superior vena cava with formation of caput medusa. Clinically, gastropathies because of accumulation of extra blood, gastropathies and enteropathies develop. Flatulence and dyspeptic symptom in the form of unstable stool, decreased appetite, nausea. Also, increasing pressure may cause splenomegaly and in severe cases hypersplenism. Splenomegaly, this is when spleen enlarge. Hypersplenism when increase function of spleen. Enlargement of veins of the anterolateral abdominal wall, the appearance of the caput medusa symptom. Progressive dysphagia due to varicose vein in the lower third of esophagus, and appearance of fluid transudate in the abdominal cavity, develop ascites. Also may develop bleeding from varicose veins of the esophagus, stomach, and hemorrhoidal plexus. How we can detect laboratory, you can find characteristic of bleeding from varicose veins or complications of bleeding as anemia and reticulocytosis. Diagnosis instrumental if it is possible to identify varicose vein using endoscopic and X-ray contrast studies of the gastrointestinal tract. And clinically, it's appear by caput medusa. You see enlargement of anterior wall veins. Enlargement may be in different shape. You see radiating enlargement, or in case of occlusion and the level of sinusoidal and pre-sinusoidal level. In case of post-sinusoidal level, you see vertical enlargement of anterior wall veins. Next symptom is liver failure syndrome. Liver failure syndrome develops when liver function is impaired due to damage or necrosis of hepatocytes. To better understanding of liver failure syndrome, you should remember all functions of liver. Of course, on the first function, first place is amino acid synthesis and synthesis of protein from amino acids. And liver produce proteins for whole of our body, including blood proteins like albumins and globulins. Also, liver takes part in fat metabolism and takes part in carbohydrate metabolism with the accumulation of glycogen and then formation of glucose from glycogen in case of need. Also, liver has detoxification function and production of bile function. In liver, we have destruction of steroid hormones, and liver has a source of vitamins and takes part in absorption of vitamins. In case of liver failure, causes of liver failure, there are hepatic and extrahepatic causes. Hepatic causes include hepatitis, disorders of blood circulation, dystrophies, hereditary liver pathology, cirrhosis, parasitic lesions, cholestasis, and tumors. Extrahepatic causes are congestive heart failure, hypoxia, chronic renal failure, endocrinopathies, and hypodysvitaminosis. Main indicators of liver failure are violation of the protein-forming function of liver or synthetic function, violation of carbohydrate function, lipid function, pigment and detoxifying function. Violation of protein-forming function of liver manifested primarily by disorders of protein synthesis and the formation of urea, the formation of serum albumin, alpha and gamma globulins, fibrinogen, and prothrombin decreases. As a result, develop hypoproteinemia, hypooncotic edema, and hemorrhagic syndrome. At the same time, if the liver is damaged, it can begin to produce gamma globulins, which are synthesized in lymphatic tissue and bone marrow in a healthy person, as well as paraproteins, qualitatively altered globulins. Violation of the synthesis of urea in the liver, the main pathway for neutralizing ammonia in the body, leads to hyperammonemia and associated toxic damage to the central nervous system. Violation of carbohydrate metabolism in liver, damage consisting a decrease in the synthesis of glycogen, a violation of its splitting, and the formation of glucose from substances of a non-carbohydrate nature, like this we call as glyconeogenesis, which causes the development of hepatogenic hypoglycemia. Violation of lipid function manifested in change of synthesis and decay, fatty acids, neutral fats, phospholipids, cholesterol, and its esters. As a result, the supply of endogenous fat to the liver is significantly increased and the formation of protein-lipid complexes is disrupted, which leads to fatty infiltration of the liver. Therefore, for example, which alcohol intoxication, poisoning, protein starvation, fatty degeneration of the liver rapidly develop. With the pathological processes in the liver, prolonged elementary hypercholesterolemia may develop, associated with the violation of the liver's ability to extract cholesterol from the blood. Violation of liver pigment function cause hyperbilirubinemias with appearing by hepatic jaundice. Violation of detoxifying function of liver in hepatocellular failure, impairment of the detoxifying function leads to development of hepatic encephalopathy and hepatic coma. Encephalopathy, also known as portosystemic encephalopathy, is the occurrence of confusion, altered level of consciousness, and coma as a result of liver failure, and may ultimately lead to death. Two factors seem to be important to the genesis of these disorders. First is severe loss of hepatocellular function, and next is shunting of blood from the portal to systemic circulation around the circulatory chronically diseased liver. There are two theories of developing of encephalopathy, hepatic encephalopathy, toxic theory and theory of GABA metabolism disorders. Toxic theory of the development of hepatic encephalopathy. According to the toxic theory, toxic substances like ammonia, phenols, and etc. penetrate the blood-brain barrier, accumulates in brain, and leads to dysfunction of the central nervous system. Theory of GABA. GABA has a neuroinhibitory effect, neurotransmitters or neurotoxins enhance the expression of benzodiazepine receptors in astrocyte, and which stimulates the metabolism of cholesterol into neurosteroids. And neurosteroids bind to the neural complex of GABA receptors, and this leads to neurotransmission disorders. Signs and symptoms depends on severity. It may be mild confusion or irritability or coma. At the beginning, it may be disturbance of consciousness, then personality changes and intellectual deterioration, low slurred speech, flapping tremors, and finally may result in coma and even death. Associated fluctuating neurologic signs include rigidity, hyperreflexia, non-specific electroencephalographic changes, and rarely seizures. Particularly characteristic is asterixis. Asterixis, also called flapping tremor or liver flap, which is a pattern of non-rhythmic, rapid extensio-flexion movements of the head and extremities, best seen when the arms are held in the extension with dorsiflexed wrist. The tremor is caused by abnormal function of the diencephalic motor centers in the brain, which regulates the muscular involved in maintaining position. Term derives from the Greek ea not and sterixis, fixed position. Hepatic encephalopathy has 4 grades. First grade, characterized by a trivial lack of awareness, euphoria or anxiety, shortened attention span, impaired performance of addition or subtraction. Grade 2, characterized by lethargy or apathy, minimal disorientation for time or place, subtle personality changes, and inappropriate behavior. Third degree, somnolence to semi-stupor, but responsive to verbal stimuli, confusion, and gross disorientation. And fourth grade is coma or full unconscious condition. Also in liver failure, develop endocrine changes. Changes are more common in alcoholic cirrhosis in active reproductive life. In the male, the changes are towards feminization, such as gynecomastia and hypogonadism. In the female, the changes are less toward masculinization, but atrophy of gonads and breast cues. And underlying mechanism appears to be change and organ sensitiveness to sex hormones in cirrhosis. Skin changes. In cirrhosis, arterial spiders, you see on the second picture, having radiating small vessels from the central arteriole, are frequent in the vascular region drained by superior vena cava, such as in the neck, face, forearms, and dorsum of hands. Less frequently may develop pulmonary erythema, especially in the hypothenar and thenar eminences, and on the palps of the fingers is observed in chronic liver disease. You see a reddish color of hypothenar and thenar eminences. Fetor hepaticus or sweetish pungent smell of the breath found in severe cases of acute and chronic hepatocellular disease. It appears to be in intestinal origin, possibly due to failure of the liver to detoxify sulfurs-containing substances absorbed from the gut. There are laboratory research methods of liver failure. Of course, in the first place, blood test, where we can find out thrombocytopenias, anemias, sometimes leukocytosis, and shift formula. Keglogram shows you thrombocytopenia and decreased prothrombin index, even which result in hemorrhages. Biochemical blood test, of course, liver enzymes, of course, bilirubin and albumin, potassium, sodium, creatinine. Creatinine, if you are suspecting developing of hepatorenal symptom as a result of damaging of liver may develop chronic kidney failure. Urine test, of course, in case of involving of kidney, where we can find protein, leukocytes, erythrocytes, and etc. And determination of content of alpha fetoprotein to detect the cause of liver failure. Instrumental diagnostic methods, there are ultrasound of abdominal organs, X-ray, MRI and CT scan, radionuclide scanning, electroencephalography for encephalopathies, liver and peritoneal biopsy. Acute and chronic liver failure manifested differently. For example, in case of acute liver failure, you could find short history of the disease, whereas chronic has long-term medical history. And acute characterized by this picture, like patients with adequate nutrition, size of liver is reduced, spleen is not enlarged, arterial spiders and pulmonary erythema are absent, symptoms of encephalopathy develop early from the onset of disease. Against the background of the current disease, jaundice occur and ascites develops late. In chronic patient with low nutrition, there is a deficiency in body weight because of decreasing synthetic function of liver, and liver is enlarged and spleen is enlarged, pulmonary erythema and arterial spiders present. Symptoms of encephalopathy develop late. The patient has a history of episodes of jaundice, and of course ascites usually precedes hepatic encephalopathy and develops early. Here you see all rich clinical picture of liver failure manifested by jaundice and also disturbances of fat metabolism, xanthelasmus and xanthomas, and spider nevis, also endocrine disorders like loss of body hair, gynecomastia, and also ascites develop, and splenomegaly, and sometimes hypersplenism, hepatomegaly, also edema, body edema, weight loss because of losing of muscle mass, and also you see here pulmonary erythema, encephalopathies, and etc. Thank you for your attention. I am wishing you strong health.